Great, good morning. Thank you everyone for coming today. Really appreciate it. Welcome to Duke's Fuqua School of Business, as well as those of you joining us online. Really appreciate it. My name is Sonny Goyle. I'm a vice president and head of corporate development at Blue Cross Blue Shield, North Carolina, and currently the interim chief strategy officer as well. So it's my honor to be up here and really appreciate everyone both being here and being online. It's a great pleasure. Duke and Blue Cross North Carolina have a long history of working together and really trying to transform healthcare, both for North Carolinians and for everyone within the United States. And in that vein, we have, over the past year, collaborated with the Duke-Margolis Center to create a speaker series to really help enlighten our brightest minds within healthcare. And this is the fifth within that series, so very excited to have everyone here and excited soon to introduce Dr. Daniel Stein. Before I do that, though, let me give a quick call out here to our next event. On April 8th, we're going to also have Dr. McCullen will be talking to Adam Bowler. Adam is a really impressive individual. He was the CEO of Landmark. He was the director of the Center of Medicare and Medicaid Innovation. And then I've got to actually read this because it's so impressive. He's also the first ever CEO of the U.S. International Development Finance Corp., a new federal agency that coins itself the America's Development Bank, and effectively going to be working with the private sector to invest monies abroad, which is fantastic news. So I hope everyone can make it. That is actually going to be in DC, if I remember correctly. So for those of us here in North Carolina, we may have to join by WebEx, but if you're in DC, I think details will be coming out shortly here. But very excited about that one as well. But let's get on to the main event. I really appreciate having Daniel here. He's fantastic. Let me give you a little bit of his background here, and hopefully I've got this right. But you did your undergraduate degree at Yale, business school at Harvard, and medicine at Johns Hopkins. Is that right? So very smart individual. It's sad he couldn't get into Duke, but we're glad to have him here. Maybe next time, but he's here. That's all that's important. And so he's got a great history in working education as well. So he has been a physician, worked with veterans, was a chief medical officer for Walmart, had various positions in Washington, D.C. as well. So really quite a great background. And he's now the CEO of Embold Health. And it's actually quite a cutting edge, interesting company that we're here to kind of learn more about, and is really working with employers as well as payers and health systems across the country to really transform healthcare. And so excited to hear from Daniel today about that. So I think our agenda today, we're going to have Daniel speak a bit about Embold Health, and then I think Dr. McCullen's going to join him for some time and do a fireside chat. We are missing the fireplace, but it'll be a fun chat nonetheless, and excited to have him. So please give a warm welcome for Dr. Daniel Stein.
Well, good morning. It's a real pleasure to be here with you all today, and it is absolutely gorgeous on this campus. So appreciate you having me, and appreciate you having me this time of year. So today we're going to talk about employers and employer-led innovation around value, and how they're using data and physician-level analytics to think differently about benefit design. But before we jump into the data part of it, I just want to give a little bit of the context here of why employers care and why you're hearing more and more news about kind of employer-led innovation in the value space. So employers are far and away the largest purchaser of healthcare in the US. Self-insured employers provide health insurance for a little over a third of the country. But despite their size, they're kind of known in the industry as being a little bit of a sleeping giant. This huge purchaser, this huge coverage entity, but one that hasn't always been as involved as the health plans and the providers in innovation. And what we're seeing is that's beginning to change. So when you think about kind of the stuff that we know in this room that we've known for a while, that's been a little newer on the employer scene, one of those things is variation in care and waste. So we all have known that there's just a tremendous amount of care in this country that's unnecessary, inappropriate, poor quality, unnecessarily expensive. And we've known about that variation, from the Dartmouth work back in the 1970s. And regardless whether you use those estimates or the National Academy's estimates or the recent, estimates in JAMA, you're talking 600, 700 plus $1 billion of care that's just wasted. So while we've known that for a while, this is a relatively new learning in the self-insured employer community. And one of the main ways that this got on the agenda of the self-insured employer community was some work that Walmart and other employers did with programs called Centers of Excellence. So what Walmart did through their Centers of Excellence program, and there are about 30 or 40 employers who have followed with them, is they went out and directly selected a group of innovative, progressive, kind of high-quality healthcare institutions. So folks that, names that you all undoubtedly are familiar with, the Cleveland Clinics, the Geisingers, the Mayos of the world. And they made it free for their employees to go be seen at those centers. So if you're a Walmart associate in Oklahoma with back pain and you're willing to go be seen at Virginia Mason in Seattle, everything is paid for. No copay, no deductible, no coinsurance travel. And they did it out of this belief that I think many of us in this room share, which is that high quality care is more cost effective. It's the right thing to do, and that ultimately it'll save money too. What they found though shocked them. They found that 50% of the patients of their own employees who were being sent to Virginia Mason, when they got there and were being reevaluated, were being told they didn't need what they were being sent there for in the first place. It was just inappropriate. It was just the wrong care. They saw this, they've seen this in knee and hip replacements as well. The number there is 25%. They've seen it in cardiac care. They've even seen it in oncology. And so for Walmart and the larger employer community that joined in with them in this effort, it was this total aha moment, which is we spend a lot of time talking about price, but we're not spending any time talking about waste, low value, unnecessary care. And we need to be spending more time talking about that. And I think the challenge with these programs is while they raised the issue, they gave visibility to this big unaddressed need, they're not really a scalable solution for a lot of employees. Most employees don't want to travel across the country to get care. A lot of care you can't ship across the country. And in reality, you shouldn't have to. They're high-quality providers in every single community in the US. We just need a data-driven, objective way to find them. And so that's really what we've taken on at Inbold, to be able to use data to help understand physician-level variation within the local community, and then to work with self-insured employers to be able to find and then feature those higher-performing providers. So this was a academic exercise for me, a corporate endeavor for, as part of working with Walmart. But it also was something that took on a bit of a personal lens for me too. So I know we have a bunch of clinicians in the room and on the web, and I'm sure all of you have gotten calls from family members at different times asking you, who should I go see? What doctor should I go to for whatever? Well, I got a call one of those days when I was working at Walmart from this woman who's my mom. And she had just seen her primary care provider who was telling her that it was time for her to go see an orthopedic surgeon, that her hip pain was getting worse, and that he was concerned that it might be time for surgery. And she called me, she said, well, Daniel, who's good? Who should I go see? And I thought about it for a minute, and I knew what I wanted in this doctor. I wanted a doctor that was going to actually evaluate her, and before he or she took her straight to surgery, make sure that that's actually what she needed, and if she could get by with physical therapy and exercise, would recommend that. I wanted a physician that, if she did need surgery, was going to do it technically well. Wasn't going to have high complication rates, And we've all read the stories about different surgeons who are using all crazy different devices and billing mechanisms. Like, I wanted one that wasn't going to gouge her from a price perspective. And then when I thought about how to find that doctor, I realized I had absolutely no clue. Like, the best I could do was call friends from med school or training or colleagues and ask for the recommendations. And I realized that was absolutely crazy. That here I was, a well-trained physician, gotten a business degree, working at the biggest company in the world. And if I didn't have access to this information, who did? And so that's why I embarked on this journey of Embold, to be able to bring a data-driven, objective solution to understanding physician-level performance. So we look at three key elements of physician performance in the evaluations that we undertake. The first is that world of unnecessary and appropriateness of care. So really trying to understand at the physician level these practice pattern variations around who's delivering care that is based on the latest evidence and where there are opportunities to be able to improve, where there's deviations from that evidence. The second world and lens that we look at is effectiveness of care, so the right care being done the right way. And here it's a mix of process-based measures that many of you are familiar with. And then where we can, we also introduce risk-adjusted outcome-based measurement to understand kind of physician-level performance in terms of outcomes of care. And then the last lens that we look at from the analytics is cost. And for us, cost is not unit prices, but it's total costs of care for caring for a similar population. And the reason we look at total cost of care is because they're institutions, undoubtedly, like some of the service lines here at Duke, that can have high unit prices relative to others in the market. But if you're not looking at total cost of care, you're not capturing the fact that that care may be delivered in a higher quality way, and you may be delivering it in a way that's more appropriate. And so we want to make sure that we're getting the full lens across that spectrum. So in order to do this work, what we realized is you really need two things that just haven't traditionally existed, or at least been commonly available in the industry. The first is data. And to be able to look at physician-level analytics and physician-level performance, you really just need a tremendous amount of data to have enough sample size at the physician level to make sure that whatever inferences we're drawing have statistical significance, have reliability associated with it. So it's fun to be here today, on the Duke side, but this is also how we ended up working closely in the Blue Cross Blue Shield world too. Because our data sharing relationship allows us to access the national Blue Cross Blue Shield data set, where they've aggregated the lives across most of their plans, which gives us enough data to be able to look at physician-level performance with meaningful sample size for meaningful results. The second thing that we realized that was missing in the industry, at least in the traditional analytics in the industry, was really sophisticated analytics trying to understand physician-level performance. You all, many of the people in this room, many of the folks on the WebEx, have done really detailed work looking at quality of care, looking at effectiveness of care. There's been some cutting-edge work looking at appropriateness of care. But it's tended to happen within the world of academics, within health services research, health economics, health policy, and it hasn't really been translated out into the industry. And so we work with a number of different academic partners and academic researchers to help bridge that divide, to help bring the world of health services research and really the sophisticated analytics that have been done in academia and to apply them into a real world setting, and then to make them available to self-insured employers to use as part of their benefit design. So one of the things I'm excited about being here today is some of the follow-up conversations that we're having over the course of the day to begin to kind of explore similar types of relationships with many of you all in the work that you're doing here. So we bring those two things together, the data with the analytics, And that's how we generate the insights. So let me show you what we mean. So I'll start with orthopedics, because this is why, this is what my mom was asking for. But I'll give you a couple other examples as well. So in orthopedics, the way that we begin our measurement journey is really looking at incident disease, so as opposed to prevalent disease. So going back to the time of diagnosis, patients newly diagnosed, in this case with osteoarthritis. And there is a large body of clinical evidence that has then been backed up in the clinical practice guidelines saying, well, look, we really should try conservative therapy before you go straight to surgery. I don't think that's anything that's particularly controversial. So we follow patients, and we see if that's happening. And then if you get the surgery, and you ultimately need it, then we looked at the outcomes that patients are receiving by different providers to begin to get some understanding how different physicians perform and to give some visibility into these performance dynamics. So let me give you an example of one of the measures from orthopedics. So there was a landmark study about 16, 17 years ago now in Nicham, looking at arthroscopy for patients newly diagnosed with arthritis. And it was a randomized controlled sham study where half the patients got arthroscopy surgery and half had a sham procedure done. Still not quite sure how they got that through the IRB, but they did. It was Texas. And the study found that there were no significant differences in outcomes for patients, surgery versus non-surgery. And there have been a number of studies since that have shown very similar results. And yet, when we look at how often this procedure is being performed out in the community today, we see that there is just a tremendous amount of variation. So let me orient you to this chart so that you understand what you're looking at here. So each one of these different bars is a different orthopedic surgeon. The market we're looking at is Dallas, for no good reason other than it's fun to pick on Dallas. But we see these results in every single community. And what you're looking at the y-axis is the percent of time that a patient with newly diagnosed arthritis is undergoing an arthroscopic procedure within the first year of diagnosis. So a procedure that's been shown to have very little benefit, a procedure that costs $10,000 to $15,000 per procedure. And yet, you see there's a 9-fold variation. You have some physicians in the top decile who are performing it relatively infrequently. You have some physicians in the lowest performing decile who are performing these procedures literally on almost a third of the patients that they're seeing. And across the board, this is happening to 1 out of 5 patients within the first year of being newly diagnosed with arthritis. So if that's overuse, this is an example of underuse. So same chart, same bars, orthopedic surgeons in Dallas. Now what you're looking at is the rates of physical therapy use prior to surgery. So every single clinical practice guideline says before you do surgery, patients should undergo physical therapy. Some of them may ultimately not need surgery, and it also tends to lead to better outcomes. And yet you see this relatively simple conservative intervention is very infrequently performed. And again, with huge variation at the physician level. It's not just in the world of appropriateness where we see this variation. We see the same thing when we go to that second bucket, effectiveness of care, how well that care is being delivered. So now, same doctors, same orthopedic surgeons in Dallas. And now what you're looking at is the rate of complications following knee and hip replacement surgery. And again, you see on the top performing side of the graph, that many doctors have very low complication rates, which is what you would expect for a relatively common procedure. But there are some doctors in this market who have incredibly high complication rates after caring for patients with knee and hip replacement. And as with the other measures, there's just a tremendous variation across. And so we view our job as using this data to bring visibility into this variation and to make these differences knowable and actionable so that we can actually improve things. So it's not just orthopedics. We have very similar findings in the other specialties as well. So I'll show you some data from obstetrics and from maternity care as well. So similar to orthopedics, the way that we do the measurement is starting at incident diagnosis. In this case, incident diagnosis is, good news, you're pregnant and expecting a baby. And we follow mom over the full course of the pregnancy, looking to see if she's getting the recommended care, both in the prenatal period, up through the pre-birth period, through the actual delivery, and then following afterwards. And we see very similar results as you saw in the orthopedics. So what you're looking at on the bottom left here now is a chart. The bars now are obstetricians, not orthopedic surgeons, but obstetricians. And the y-axis, the rate, is low-risk pregnancy C-sections. So this is the percent of moms by physician who are being delivered via C-section. Now, I want to be clear here. This is low-risk pregnancy only. Moms under 35 don't have diabetes or preeclampsia or gestational hypertension. So this is a cohort that is selected to be low risk. And you see that some physicians in that market, some obstetricians, are performing C-sections 10 to 15% of the time, which is consistent with what the WHO guidelines say, is probably the right amount of C-sections. Some are performing C-sections on low-risk moms literally over 50% of the time. And the average in this market, and this average holds true in most of the markets we look at, is around 30% of the time. And again, you see the same type of data when you look at the effectiveness measures. So the example I'm sharing there is also a complication rate following low-risk pregnancy. And not surprisingly, this translates into just a huge amount of spread in terms of total cost of care. So what we do, before telling you how we make this information available to employers and what they're doing with it, we take all these different data points at the physician level across the different measures in the specialty. We bring them together to then give you a profile of specific physician performance. And then we make that information available to employers to be able to then feature those physicians as part of their benefit offering. And for them, what they want is pretty clear. I want the doctors who are delivering care that's medically appropriate, higher quality, and that are doing it, at relatively cost-effective structures. So one of the things that, in audiences like this, I tend to get asked a fair amount about is, why are you measuring at the physician level? Why not the health system or the ACO or the hospital level? And the answer is, we do look at those too, but I'll show you why we do it at the physician level. So we've taken that, in this example, what we've done is taken that same measure, low-risk pregnancy C-section rate from Dallas, and categorized the physicians by by which health system they're affiliated with. There are 4 major health systems in Dallas. And so this shows you how those doctors stack up as part of those health systems. It's not one of those charts that if you stare at it long enough, a pattern will emerge. It's a pretty random distribution. And so if you break it down and say, well, let's not look at all the doctors, let's just look at a single health system's doctors, so one of the 4 health systems, you see within that health system, in general, there's as much spread within the doctors in that health system as there is across all the doctors in the market. And then if you stack up all 4 of those health systems to see how they compare, what you see is 3 health systems perform very similarly, almost the exact amount of spread as in the market. And one health system does a little bit better on those kind of outlier management cases of managing the physicians at the extreme use of C-sections. And we see the same thing when you look at other specialties too. So to keep it consistent, I'm showing you that same arthroscopy measure from orthopedics. And again, now we've separated into the health systems that are ACOs in that market. And again, you just see a tremendous amount of variation within those health systems. And so that's why we look at physicians, not just at the hospital and the health system, because that's where the opportunity exists around driving greater consistency in managing this variation to improve performance. So I'm going to switch gears and tell you now about how employers, what they're doing with this data, and how they're thinking about this. So there's definitely a focus in the industry right now within the self-insured employer community around quality. They want high quality care, and they want high quality care for their employees, and they want high quality care in the communities where they have a strong presence. And so what we do is we make the data available to them to understand in the communities where they have a presence, how the different doctors perform, and how those doctors perform relative to where their employees are based and which doctors their employees are seeing today. So they can understand the opportunity if they start featuring certain physicians in that market. We then work closely with the health plan, so back to the Blue Cross Blue Shield relationships, to be able to integrate this within the health plan. A lot of employers want to keep their health plan. They want to be able to do feature high quality providers on top of their existing health plan chassis. It's a lot less disruption for them than having to go do things on their own like centers of excellence. And so we integrate it within the health plan to be able to feature certain providers over others and to make sure that all parts of the health plan are also pointing towards those same group of providers. And then the third component that we offer to employers is just a tool to be able to look up information on providers. When their employees have care needs, to find those physicians who are being featured as part of their benefit offering and who are being featured as part of their health plan. And what employers say is, look, we don't want to cut providers out of our networks. That's not what we're in the business of doing. What we want to do is make it easy for our employees to go use those providers who are going to consistently deliver higher quality care. And if we can do that on top of our existing infrastructure in collaboration with our health plans and collaboration with our providers, that's a win-win for us and for our partners. So one of the things that I've been really pleasantly surprised with and encouraged by in the employer community is this commitment not just to quality, but this commitment to improvement. When you talk to employers, they realize as they get more engaged and more involved in the purchase of healthcare, as they're getting more engaged and involved in actually making decisions for their employees and helping direct them to higher quality providers, they want to do this in a way that creates momentum and creates an energy around improvement, a catalyst for it. And so they really have gotten behind our approach, which is to be transparent with the measures, transparent with the methodology, and to share the results with physicians. And they're doing this both out of that mission orientation around quality, but also I think they share a belief that we have, that I think many in this room have, which is most of us got into this industry because we want to deliver high quality care. And given the right incentives, given the right tools, given the right data, we as a profession will improve. So I've been really encouraged by the embrace of the employer community, not just in quality for their own employees, but also realizing the role that they play in being able to help drive this type of change across the industry. So what I'm going to share from you last is a set of headlines. And Mark, you may have seen this before, but these headlines actually come from Walmart as part of one of their presentations. And when you look at their goals as representative of what a lot of employers want in the industry, you see they want to use their market power, their purchasing clout, to be a force for good, to improve quality. They realize they have that opportunity. And they want to do it in a way that not only helps them and helps their employees, but also helps providers and gives them a way, a mechanism to be able to improve too. So when we take a step back and think about employer-led innovation and the role that employers have to play in this space, that to me is it. It's to be a force for having the conversation around quality and to create incentives to be able to have the type of collaborations like we're having here today. Thank you very much.
Daniel, thanks very much. Please have a seat in front of our non-fireplace so we can start to talk a little bit about the really interesting presentation that you just went through. So we're going to talk for a bit, and then, because you're here in the room, I want to open this up to broader discussion too. There's a lot that you talked about today, and the clear focus here is on what employers supporting their employees can do to drive healthcare reform. And I want to focus on some discussion around that. But first, if you look at the big picture, you mentioned that employers are trying to do more to help improve quality, and you can see why they really would care about it, because it matters for their employees' well-being, and it matters for their productivity, all kinds of reasons for engagement in this. But if you look at a few of the markers, I guess there's some reasons for concern or questions about just how effective employers have been. We work with a group called the Healthcare Payment Learning and Action Network, national collaborative public-private effort, including with a lot of employers, including Walmart actually, that among other things tracks what's going on around payment for quality, value-based payment. And if you look at employer plans commercial, they're kind of behind in shifting away from fee-for-service and focusing on negotiating discounts on fee-for-service rather than focusing on medical homes and accountability for total costs on the payer side. And as you know, there have been some big trends in employer coverage in the last decade towards high deductible plans and end up sort of shifting a lot of the responsibility for the costs of higher care to employees, particularly those with chronic illnesses. So what's your sense of how well employers are doing at this, and do they need to rethink the strategic approach?
Yes, is the short answer. There's a lot of pent-up demand in the employer market. I think they've realized that a lot of their efforts to date, which have been, a lot of coalition type work, have not had the same level of effectiveness as other sectors in the industry. I think there's been a lot of passive kind of taking. So they'll take what the health plan brings to them, what the benefits consultant brings to them, and they're kind of a conduit of it, as opposed to being more active and more engaged. I think you actually hit the nail on the head why that's changing. Yes, they care about quality. They've cared about quality for a while. Like, that's not a new. Yes, they realize they need to be more active with their health plans. They've realized that for a while. I think the big thing that's changed is they've run out of money. So for the last 10 years, through benefit design and premiums, they've passed more and more of the costs onto their employees. Higher deductibles, higher premiums, higher copays, higher coinsurance. And there's a realization now in the industry, and this is not just for lower wage employers. This is true for higher skilled employees as well. They can't go any further. So every incremental cost that in marginal rate increase year over year, they're going to have to bear. And they realize that they've got to be more active if they want to manage that.
Yeah.
And I think they also realize, to your point around the unit price, discussions that have typically dominated the industry, that's a little bit of a red herring. It's not that price doesn't matter, but the marginal opportunity there relative to stuff like this, quality and unnecessary care, is so much smaller. So that's what we're hearing from employers, and what gives me hope that they're willing to be much more engaged and active than they have been historically.
And in terms of getting more active in really trying to support employees in making higher value choices, and we'll get to that in a minute, you talked about how some of these efforts started with centers of excellence. By the way, I did not notice any stars over the Durham or Research Triangle areas. Or something I should read into that?
It should apply.
But I totally get your point, is that these referrals away from where people are, people who most of these costs are associated with chronic diseases, can help with certain steps, but really not changing the whole course of care. So you talked about a number of ways of extending that. So some of these centers for excellence are about musculoskeletal conditions and the like. Could you say a little bit more about the range of areas where you're really focusing? I saw musculoskeletal, I saw maternity care. Are those kind of the big places to start? How much broader is this effort going to be, and do you need to start somewhere?
Yeah, so currently we cover about 70% of spend for a typical commercial employer. Primary care, endocrine, pulmonary, GI, musculoskeletal, spine, obstetrics, cardiology. I'm sure I'm forgetting a few. I think our goal in the work of the goal of the employers that we're working with is to keep as much care in the local community as possible for that exact reason. Even something seemingly relatively discrete and episodic, like a knee or a hip replacement, there's a lot of evaluation and a lot of treatment that should be happening before it. You have the surgery, and then you need to come back and get physical therapy and get plugged back into the community ecosystem. And so shipping people across the country, while it has those demonstrable benefits in terms of quality improvement, unnecessary care reduction, shorter PTO and time away from work, shorter disability rates, it comes at a cost. And so I think that really the goal is keep that care in the community, but don't do that at the sacrifice of quality. Find those providers who are going to get the same outcomes, but do it in a way that stays within the local community.
And as you're doing this, you highlighted that this is measurement, like you said, not about just who's got the highest specific fee-for-service prices, but total cost of care for the whole set of services, including the institutional services associated with these different types of episodes of care that people need. You talked about quality, though, as well, both in terms of appropriateness of the care processes and outcomes. How's it been going as you piloted this in some regions already? You've just started discussing this with a lot of clinicians out there. Is the reaction that, oh, I'm really high and on these overuse charts. I'm really high on costs. I'm going to change that right now. Is that how it goes, or is it more like the sort of the stages of grief? Denial, anger, bargaining, et cetera, et cetera. How's the reaction going?
It's been both. It's been really interesting to share data with providers and with health systems like here, where at first it's surprise. That's the immediate reaction that we find, which is surprise at the level of variation that exists. It's like one of those things where it's like, we know it's there, we know it's in the ether, we know there's a lot of variation, but when you show it in a local market, within a local community, it never ceases to amaze me just how surprised people are, how big the change in the magnitude is. With individual providers, it's really interesting. What we hear from a lot of providers is they get next to no feedback today. So the feedback, if they're getting any, is around billing or RVUs. Yeah. They're not really getting a lot of clinical feedback. And so for them, it is definitely those stages of acceptance and grief. Everyone wants to be on the left-hand side of the curve, and if you're not, that's a blow. And the usual reaction is your data's wrong, and my patients are sicker.
And so how do you walk them through those responses?
Yeah, we just tell them how we do it. I mean, our approach on this is to just be transparent. Here's how we do the measurement. Here's how it gets applied in the methodology. Here's the data sets that we're using. We always are looking for feedback. So if there are things that they think we can do better, that's great. We want to hear that. And then we show them how they rank on those measures relative to de-identified peers. And the thing that's really interesting is, there's a spectrum of sophistication of physicians and physician groups regarding data. Some who are in risk-based contracts and have been very involved in Medicare Advantage, they understand data. And what you see is on the effectiveness stuff, particularly the more traditional HEDIS, they've actually managed their variation pretty tightly. So some of these groups perform well, but they also perform within a relatively narrow range on the effectiveness stuff. And then when you show them either the risk-adjusted outcome data in effectiveness, or more commonly the appropriateness measures, which they've never seen before, that's where they're all over the place. And so for the groups that are used to seeing data and have kind of put in place processes to begin to manage that variation, they get it. For the groups where this is the first time they've ever seen anything like this, it generally takes more conversations than just a single one. And so what we generally try to do is kind of walk through the process, first with the approach, the measures, the methodology. Then we'll show some data. Then we'll begin to kind of expose how they compare relative.
Although you are, at least at the surface, an employer-focused company, it sounds like you're doing a lot of work on practice improvement with clinicians.
Yeah, we've made a commitment that we will share the results with physicians, in terms of how they improve. I have a fundamental aversion to black boxes. I think we in the industry have hid behind black boxes for way too long. And at the end of the day, it's the right thing to do. If you're going to evaluate somebody, they should know how they're being evaluated. But back to that, goal that we talked about at the end. Our goal is to help people improve. I think that's what our employers want. Certainly, it's what we want and what I want. And so that's why we create individual physician-level reports in the markets for anyone who wants to know how they perform. We share it with them.
How good are the measures today? I maybe won't put you on the spot to say, a scale of 1 to 10, or how far are we from, maybe I will, how far are we from where you'd like to be, and where do you see the biggest opportunities for improvement? My experience of the way this reform stuff usually goes is you start out with a goal in mind, but the quality of the data, the quality of supports are just not there, and it's not until you really get into doing the work that you can start making things better. How's it going from your standpoint?
We've been really pleasantly surprised how much better measures we can develop than what exists in the industry today. When we look at performance relative to the more traditional HEDIS stuff, we've been really encouraged by
in terms of appropriateness and some outcome measures.
And the quality of the measures themselves. So we've got a partnership with an integrated delivery system in the Midwest, where we have access to both their EMR and they own a health plan in their health plan. And so when we go in and as part of our validation, we'll look at how the measures perform using claims-based data to try to approximate the clinical. So when we talk about performance, kind of seeing how they perform, we've been encouraged at the level of performance, what we're able to capture. I think the next big step change, for us, being out there in the market, talking with providers has been immensely helpful, because whether it's said in the spirit of helpfulness or not, the feedback that we get is just tremendous, and it's all stuff that we can learn and take back and improve on. I think the next big step change you'll see in the industry is when we begin to integrate claims data with other data sets. Clinical, to be able to get a more nuanced picture, particularly in specialties where you really need a rich clinical nuanced picture, like oncology, and then patient data too. And I know you guys have done a lot of work around patient-reported outcomes, but to be able to incorporate those other elements of care, beyond just what you're able to capture with administrative billing data, which, while it is large and ubiquitous, it has challenges, as you know.
Do you see Embold playing a big role in driving, piloting, and then driving the collection of these sort of better, more meaningful measures like patient-reported outcomes?
Yeah, and that's one of the reasons why we built these patient-facing tools.
Yeah.
To be perfectly direct, it's not just to present information to employees, but it's to be a place where we can get feedback back from them. I think the industry.
And this is going to be more than those like stars that you showed earlier. This is going to be something meaningful tied to the conditions that really matter to the
That's exactly right. That's exactly right. That's what that tool does today. But it really needs to be bi-directional. It's not just us showing information to you. We should be leveraging that to get that type of information back from patients too.
Now, can you say a little bit more about how the data and the analytics informed by your interaction back and forth with providers is then translating into what employees actually experience. So they're clearly getting some more information and hopefully in ways that's not too overwhelming. I'm sure that's an important area too for how you actually engage the employees. In addition, they're getting some different kinds of benefits, right? So the idea is if they actually engage with and start using some of these higher rated providers on these dimensions of appropriateness and results and total cost, they pay less?
That's right. So what most employers that we're working with have implemented and are interested in is that, a tiered benefit design, where they are paying more of the care in the form of lower copays and lower deductibles for their employees to use those providers who are higher quality.
How much less?
A lot less. I mean, it depends on the employer, it depends on the culture, but we've got some employers who are literally thinking in and out of network type differential rates. That's how important it is to them. And then this is also why we do the work to integrate this in the health plan. Because it's not just a financial incentive. What we want is for everything to point you to those providers that are being featured. So that includes the customer service and the member services, the care management nurses when they're calling you, the prior auth, the med necessity. Really the goal is to have everything pointing a single direction, and to make it easier and financially advantageous for the employees to use those providers.
Is it too early to say how much employees are responding or what seems to be the key features as part of this whole set of supports and decision choice and savings and out-of-pocket payments?
We don't have the data yet, so it is too early. I think one of the things that we were concerned about from the employee perspective is this perception of limiting choice.
Yeah.
Was that going to be a problem? Or was it going to be a perceived benefit, that you're featuring certain providers over others and investing in those benefit offering? So far, we have not gotten a lot of pushback around that choice thing, but it's still early too.
Yeah, I mean, it is still the case that most employees are in some kind of PPO type plan, especially for some of the employers that you're working with, and the employers have had a hard time saying, "Oh no, we just don't want you to go to this doctor, this provider." But it sounds like this is a different way, other than just out-of-pocket payments, to help employees shift without completely taking away the choice.
That's exactly right, and to a T, every single employer that we're working with leads with quality.
Yeah.
And that's not a disingenuous lead. That's genuinely why they're doing this, as opposed to the narrow network offering that they're getting from their health plan. But it's also how they're communicating it to their employees.
Now, there have been efforts, as you alluded to, over the last couple of decades to try to get to better quality and value by changing the way that providers are paid. And that's not where you're focusing in this effort. A lot of these providers have fee-for-service contracts. Some of them, as you mentioned, are in risk contracts, ACOs, things like that. Do you see these coming together? Because one of the big criticisms of the provider-focused reforms is they don't really engage the consumers all that much.
Yeah, I sure hope so. I mean, to me, these worlds are so complementary and synergistic. What are you paying? We should be paying for value. And then how are we directing people? How are we constructing networks and benefit design? That should be based around value too. I think this is a lever that the employers can pay that's easier than the value-based purchasing payment stuff, which has to be
easier in the sense that most employers aren't in a position to have enough market share with a provider to get them to change their contract. I guess maybe Boeing can do it in Seattle, but
even Boeing,
still a small share.
Yeah, still a small share in Seattle, and maybe they can do it in Seattle, but in Charleston, they're still having to work very closely with their health plan, and their health plan is doing a lot of those contracts. So most employers just don't have the scale or the sophistication or market share to be doing direct contracts. And so this, to me, is the opportunity with the work that the plans can bring, which is the plans need to be picking up this mantle around value-based payment. In these two worlds, the same goal, higher quality, higher value, two very complementary strategies to get there that should be coming together.
Now, you mentioned some provider groups that had experience in Medicare Advantage, which does move, is a way for providers to move way away from fee-for-service payments and getting payments that are tied to results and paid at the person level. That they'd had more experience and so were kind of more familiar when these models came in. But if I was reading your slide right, when you were talking about some organizations, health systems, including ACOs, where you found what looked like just as much variation in your physician measures as in the organizations that are still just in fee-for-service. Is that right?
Yes, almost to a T in almost every single market that we look at. When you look within the health systems, regardless whether they are an ACO health system or not an ACO, and most of them are.
So when you talk to these health systems that are out there talking about how they're moving into value-based payment and they formed ACOs, what do they say about this?
It depends on who at the health system we're talking to. If it's the COO or the chief operating officer, they say, we have to be managing this variation, whether that's from a quality perspective or whether that's from an operational efficiency perspective. When you talk to the CFO, they get a little nervous. It didn't show you any of the spine care measures, but those are big revenue drivers for a lot of these hospitals and health systems. And so when we talk about how much of that care may be unnecessary or potentially avoidable, they have to think about what that means financially for them in the fee-for-service world. And then generally the CEO sees both sides of that spectrum. And that's where we get the really uncomfortable analogies like, feed in two different canoes and trying to balance.
Yeah, which doesn't seem like a good way to move forward.
It always makes me feel quite uncomfortable.
Have you been able to help any of these organizations engage their physicians more, since you do seem to be getting physician attention with your physician level data in a way that probably the more aggregate data doesn't?
Yeah, we're working on that right now, Mark. Yeah. We're getting a lot of interest from health systems around how we can make the same data available to the system. Not just employers, not just individual physicians, but to the systems as well.
And just following up on this, I know your focus has been on employers, but from this discussion, it sounds like you're also doing a fair amount of direct provider engagement. You're doing some health system engagement. If you're working on benefit redesign, that's going to involve health plans, including health plans that are trying to advance some of these alternative payment models for their providers too. Is your business strategy going to include building out that kind of synergistic approach, not just employers, but employers plus health systems plus health plans to really align all of these supports for reform?
Yeah, we're already working with these groups. For us, just the linchpin in this is the self-insured employer. They're the ones who help create the incentive, who help move this forward. And they, through that work together, give both the health plans and the health systems a vehicle, a path to work around shared goals. What we view as our role is to be a third-party objective source of data, of performance, of analytics, so that when, regardless whether it's the employer or the health plan or the health system or the providers, we're all working off the same understanding of what that performance is.
Just helping them work together off objective facts towards a shared goal around value.
Yeah, exactly. And I think the thing that we see is, there are a lot of built up relationships, particularly between the health systems, the health plans and the employers, where there isn't necessarily a lot of trust in the data that's been shared back and forth historically, or the motives behind that data. And so the role that we play is, look, we're an honest broker. We have one goal only, and that goal is to measure with as high a fidelity performance as we can. Not an easy goal, one we're constantly learning, constantly trying to get better at, but to try to be able to sit between those different relationships, with that shared understanding of we're going towards value.
So how do you see the Embold journey going from here? Remember, you made some headlines back last fall when Walmart announced some of these pilots, I think, in several parts of the country, including Dallas-Fort Worth, if I remember right.
Yep.
Yeah, so that definitely got some provider attention there. Are those, what's the status of the pilots there? Or do you expect those to expand over the next few years? What's the course forward from here?
Yeah, it's been great. So the initial work with Walmart obviously got a lot of attention, which meant we had to respond to a lot of inquiries. But that work's been great. We've been using the first few months of these, of being live with them, to engage with the provider community. So this isn't a surprise. So they understand and they've got the chance to push and ask questions around the measures and the methodology. We launched with another employer in the state of Florida back in January. Similar type of process where we spent a lot of time engaging with the provider community before they went live with benefit design. So there wasn't a surprise. Doing the same thing out in Washington State with a big employer now. All very different types of employers that we've been working with, which has been encouraging. Back to your original question, like, are employers really ready to move? Really ready to do something, or is this just another talking point for them? And then for us, it's just expanding employers over time. As we add additional employers, it has the advantage of creating more market share, which then makes the relationships and the engagement with the providers and the health systems all the more meaningful.
Does this only work with large employers? Is there a way to extend these kinds of tools to medium size? I mean, that's where a lot of the lives are. Yeah.
Yeah, we're having these conversations with the plans now. So we started, working with the plans in the context of their large self-insured, the jumbo accounts, and what they quickly realized is, well, this is great for that book of business, but we have other employers who would be interested as well. And then some of them are also going to kind of their fully insured books too. So we'll see how that evolves over the next couple of years. But I think we view there being just as much demand in the mid-sized employer market. They probably won't be using our network optimizer tool to curate their benefit design themselves and do a custom configuration. It'll be more of a standard offering. But I think in terms of the demand for that product, it likely will be there too.
I want to open this up to questions in just a second, but maybe I'll channel some of the local physicians in the room and asking, so how long till we see this in the Triangle area?
I don't know. It's a good question. We certainly have had some conversations with employers in the state. I think we'd be very excited to have the opportunity to come here.
Great.
And to work with you guys, both on the academic side, but also on the health system side too.
All right. Well, we do have some time for questions. So I think there are going to be microphones in the audience, and and maybe start with Courtney.
Thanks so much. That was really interesting. I'm wondering, besides using price and co-insurance differences and in-network versus out-of-network, ways to incentivize employees to change to these lower or higher quality providers, whether employers are using different strategies like default choices to them, so they choose the right providers, at least among new employees, and also restricting choice sets. What are employers doing to get people to use this information and choose what's best for them?
So I'll share what some of the employers we're working with are doing, but what I'll tell you is there's an appetite within the employer community to be more creative around this type of work. So some employers have on-site clinics, where their employees receive urgent care and or primary care services. So they're thinking about, how do I embed this as a referral tool? There's a lot of research that they've done, and the health plans have done this work, which is ranking order. When you're showing people choice, how many choices are you showing them, and how are you sequencing those choices? So even in the absence of benefit design, making it easy to choose providers that they want them to see because they're higher quality. We've done some work with employers around peer communities within the employees, having kind of early adopters and then having them use them to help spread the word. And communicate.
So like employee key opinion leaders, or interesting.
Yeah, you'd be surprised the number of Facebook groups that companies have for their employees. and how they communicate with each other around, I mean, right now it's around benefit selection and benefit, open enrollment type stuff, but around stuff like this too. So I think there's an interest in exploring different ways, and one of the things that it's on us to study is what's most effective, what actually works, and what moves the needle versus what doesn't.
Good question over here, and then.
Thank you so much for that really, really excellent presentation. And I'm really glad you hit on the fact that appropriateness of care is where there's a huge opportunity to save on medical spend. When you're looking at large employer groups that have medical spend across a number of different conditions, how many different appropriateness of care metrics do you have to look at to really be impactful?
It's a great question. I don't know that I have a great answer for you. I'll tell you how we do it.
Sure.
So we pick the conditions based on where the biggest bucket of spend is. That's both cost as well as utilization. And it gets back to that impact question, because that's where you're also going to have the biggest impact. And for each one of those conditions, we are measuring appropriateness of care along with the effectiveness of care. And then we bring those different measures together at the individual physician level. In reality, we're not trying to measure care at the individual patient level to say this care was high quality or appropriate and this care wasn't for any individual member. But instead, what we're really trying to do is tease out practice patterns. So how do different providers, what's their thumbprint? What do they look like? And so we've taken the perspective of the best way to do that is by looking at multiple different aspects of care over time across a big patient population. I don't think we've tried to reduce it down to what's the bare minimum number that we could do. So I don't have a great answer to that. But what I can tell you is you're able to see it with a handful of measures, certainly a dozen measures within any specialty. You just get these very different spreads in how different providers practice. And not surprisingly, there tends to be pretty strong correlation between appropriateness of care measures within that specialty.
So there's really not a standard way in which you apply what you're doing. What you really do is you take a group that has a specific population and you look at where their costs are, and from that information, you then derive which metrics you're going to use.
No, the measures are standard.
They are standard, okay.
The measures are standard, the methodology, the way the statistical weights, the principal component analysis and the regression models, all that is standard. The only thing that is customized for a specific employee and in a specific market is where they want to do the curation, to what level they want to curate different providers, and then also understanding the opportunity, where their employees are seeing care today and what the disruption then looks like, what the changes would need to be. That's the only thing that's standardized. The rest of the analytics are all the same.
And one last question, because one of the things that I have noticed is that providers tend to understand this, payers tend to understand this, and increasingly large employer groups understand this. But when you get down to the individual patient, they don't always understand this, and that's where you're really disrupting what's happening. What's your strategy, or how do you message and get down to the level of an employee to make a different decision with how they're going to get their health care?
So we're spending a lot of time right now looking at what's the right level and type of information to share with an employee. There's the historical 1, 2, 3, 4, 5 stars, which clearly is not enough information. In our employee feedback and focus groups, and what we hear from employers is they just don't know what that means. That's not enough to make a meaningful decision. But showing, somebody with arthritis, the, sepsis and pneumonia and DVT complication rate by surgeon is also not the right level of information. And so what we've been working with some of our employers is creating something in between there, where it's showing them some information using the real data around practice patterns, around things that matter, like right care, like appropriate prescribing, like effective treatment, like imaging that's indicated, in ways that they can understand, which kind of strikes that balance between enough information that they understand this is real data, real results, real performance, but not so much information that it overwhelms and it just becomes too technical. So I don't have a great answer to that now, except to say this is a tension that we're working through live.
Good. All right. Lots of questions. We'll try to get to as many as possible.
Thank you for your presentation. I think you're in the right area. I have a provider set of questions and an employer set of questions. Kind of on the provider side, how are you dealing with risk adjustment, and how do you deal, particularly since you're talking about incidence and long-term follow-up, how do you deal with insurance churn?
Yep.
On the employer side, my key question is, health plans have been in this area for a long time, and certainly there have been a number of vendors. So how are you different from Optum, McKesson, Ventana, so on and so forth?
Yep. On the provider side, we start the risk adjustment, creating as homogeneous a cohort as possible, and then we apply standard commercial government HCC risk adjustment at the individual patient back to the provider level. And then we also use the ARC socioeconomic status risk adjustment model to try to adjust as best we can for those elements of patient care. On the payer side, I can tell you, I started this journey with absolutely no intent to create a company.
I
remember I talked with you early about this. I planned just to go license technology that was on the market from an analytic firm. And what I realized was there just wasn't a lot of clinical sophistication in a lot of those tools. This world of appropriateness was largely unmeasured. And a lot of the tools were kind of focused on cost or price or episode cost. And I found it very unsatisfying whenever I asked, how do you do this? Or help me understand how you do attribution, or help me understand how you're aggregating total cost of care, or defining the bundles, or whatever it is, the logic behind. The typical answer I got was that it was proprietary and confidential, which I just personally learned to develop a bit of a distrust for that. I can't tell you that means I'm not sure if it's real, or what the science is behind it. So that's why.
All right. Jeff.
I really appreciated the previous comment around aversion to a black box, and this is kind of where the previous gentleman's question was going. But as you think about all of these players in space, like the Optums and the McKesson, how do you weigh the transparency that you speak so highly of with the kind of like strategic nature of attempting to create a moat and prevent fast followers that will try to do the same thing as you?
Yeah. So we're publishing our measures and our methodology in the academic literature. I think it's important, both to have the peer review, but also to help get it out there. Certainly there are different competitive dynamics that introduces, when you publish your approach. Quite candidly, this is pretty hard work.
It's not just the methods, it's how you apply them and all of these organizations, including the providers that you have to work with, too.
Correct, exactly. It's a lot of hard work. And we hope others will join us in this work because we think it's important. But I'm less worried about, followers being able to replicate.
And then we had some more questions on both sides. Not sure where you all want to go to next over here.
Hi, I'm wondering, you mentioned employers being the linchpin, and are you doing anything to help employers have those conversations with the physicians and the provider groups? And what I've really heard is that employers say, I don't know anything about quality and appropriateness, so how am I supposed to go talk to somebody? And certainly a large employer like Walmart has those resources, but a smaller, medium-sized employer that is in the business of making clothes or issuing loans might not have all that expertise. So do you envision in Bold just continuing to play that role, or are you trying to do anything with educating employers and empowering them to talk directly to providers?
So both kind of our, back to the physician training, the see one, do one, teach one mindset that permeates medical school.
You're trying to evolve from that,
Yeah.
I think, but
Hopefully, we've gotten a little more sophisticated than that. That's actually a very similar strategy that we take with employers, where sometimes we'll have the conversations on their behalf. What we like to do is have the conversation with them in the room, employer, us, providers. And then what we find is that most of the employers that are comfortable after we've done a few of those, of having those conversations on their own. And where it evolves to, Mark, is the question you asked, which is, a lot of those health systems then want to work together with us. And so we're having to figure out what that means.
yeah, and I think health plans can help here too, but many employers who don't, as you said, don't have a whole lot of in-house expertise and can't afford it, they rely on benefit consultants, advisors, who typically haven't focused on what you're focusing on. Are they coming around too?
Yeah, they get it. I mean, it's a complicated web.
They get it, but are they working with you?
They're working with us. They're still figuring it out. They figured out the benefits consultants and the advisors, play a very specific role in the industry. And it's actually very similar to the relationship with health plans, where we come in, we're new, we're going direct to the employer, and that creates some fear.
Mm-hmm.
But we started working with the big houses, largely on the back end, on the science side, on the actuarial analysis. And as they dug in and understood it, they then have actually become quite helpful champions and channel partners in the market to kind of more forward-leaning, innovative employers.
Interesting. I think we got time for a couple more questions. Dev?
Yeah, again, great presentation. I helped lead some of this work at Duke, and I think I saw my first Blue Cross or payer data set on variation over a decade ago, and it was orthopedic surgery. It was knees, variation across North Carolina. When we start to see our own data, one of the things we realize that it's still very poor. I mean, it's better, it's getting better. You really need to marry it with the clinical data. You can't get physician buy-in if you go strictly on claims data and say, look what the payers are saying. You got to add your own clinical data. And then fundamentally, it requires workflow change. We can do that kind of stuff at Duke. How are you able to convince providers that they need to change if you don't have full view into clinical data and ability to help them actually change the way they deliver care?
So the clinical data, to me, that's the next frontier of this work. It's how do you marry up claims data with the clinical? The nice thing about the claims is it's not just that it's standardized. It also gives you a full profile of the member, not just for the care that they're receiving in one institution, but across institutions in town too. So providers don't always have visibility. But to your point, the clinical data gives you a richness to that information of the care that's being delivered. So that's how I see this evolving over time. In terms of how do we get providers to change, we don't view that as our job. At the end of the day, that's on the providers and that's on the health systems. We want to enable it. We want to be helpful. We want to give them tools. We want to give them data to be able to, continue on that journey and do that work. But fundamentally, that's the health system and that's the provider's job to decide how they want to deliver care individually and how they want to deliver care within their institution.
Yeah, it will be interesting to see how this unfolds, since you do view as your job helping employees make higher value choices for their care, and these issues around data quality, I think, are going to continue to be important in all of that too.
I agree.
Yeah. Over here, and we're about out of time. Great discussion.
How do you work with newer providers who may not necessarily have as robust historical data, and how do you kind of have conversations with them to integrate them into your networks?
So we don't rate them. If you're new and we don't have enough data, if you're new to an area and you don't have enough data, at an academic place like Duke, you have part-time providers who don't always have very high volumes. For those providers, we have a category which we call non-evaluated, because we don't want to be assigning a evaluation to that provider that we don't have as much confidence in, in terms of sample size.
Great. Any final thoughts?
No, I think this, where you all are sitting here, between the work that you're doing here within Duke as the medical institution, the work that you're in the collaboration you're doing with the health plan, the sponsor of this event, Blue Cross of North Carolina, along with Duke, and then the work that you're doing in the research and on the academic side of it to understand quality and understand this variation and translate what that means. I mean, to me, this is the work. So for me, it's exciting to be here and to be able to spend the day with you and to be able to learn.
Great. Adam, sorry, I was about to introduce our next speaker for the next time. But Daniel, thank you so much for joining us today. Good luck on the next steps in this very important journey. Thank you.
Thanks, Mark.
Before we all tune out, I did want to mention Adam again. So Adam Bowler is going to be our next speaker in our April session. Adam is, you heard earlier from Sunny, is the current director of the U.S. International Development Finance Corporation. What is that? It's a new entity that brings together a lot of the U.S. government efforts, along with private sector and financiers in the U.S. and around the world, to support private sector innovation in lower and middle income countries around the world. A lot of that innovation is happening in healthcare, very much in line with the types of innovative work that we've talked about here in the U.S. today. In addition to that, Adam is the former director of the Center for Medicare and Medicaid Innovation, so has some really interesting perspectives as well on how healthcare reform is going in the U.S. As well as around the world, with a special emphasis on innovative private sector solutions in both cases. So we hope you'll join us for that. But for right now, thanks for joining us today and being part of the Point of Care Seminar Series. Have a good rest of the day.